9:54. So we should have started.
Sir, it's 9 now. Nilesh, can I start?
Yes, from my end, it's okay.
So good evening, everyone. I welcome you all on behalf of YOSI legal core team to this wonderful evening. So we have had a series of webinars, namely covering the topic like consent, Consumer Protection Act, record keeping, indemnity insurance, how to respond to a legal notice, medico-legal issues regarding cluster tasks and cluster endophthalmitis, telemedicine and its medico-legal aspect. And today, I'm very proud to say that we are entering in the 8th session, wherein we are going to discuss the cataract surgery and related medico-legal aspects. So let me introduce you all to the panelists once again. We have with us Dr. Anand Deshpande, sir. He is director and eye surgeon at Guru Prasad Netra Rugnalaya at Aurangabad. He is also director at Indian Medico-Legal Consulting Services Private Limited. He is chairman legal committee of AIOS, Maharashtra Ophthalmological Society and Karnataka Ophthalmological Society as well. He is faculty of law and visiting professor of Symbiosis Law College, Pune. He has written various books like Legal Aspects in Ophthalmology, to name a few. So thank you, Anand sir, for being with us since our first session. Next, we have with us Dr. Prakash Marathe, sir. He is another source of information for us, and he has been with us for all these sessions. So, sir is consultant ophthalmologist at Netra Yogi Eye Clinic in Pune. He's senior vice president, IMA Maharashtra State. He is managing committee member of AIOS. He is CWC member, National IMA Headquarters, New Delhi. He has been trustee and past president of Pune Ophthalmological Society. He is trustee and past president of Indian Medical Association of Pune. And he is past president of Maharashtra Ophthalmological Society. So we once again welcome you, sir. Then we have with us Dr. Manoj Mathur, sir. He is in private practice with interest in glaucoma and comprehensive ophthalmology. He is advisor and past president of Telangana Ophthalmological Society and Hyderabad Ophthalmologist Association. He has served as MC member AIOS for 2 terms. He is recipient of various national and international awards. He'll be joining us shortly. So let me introduce you all to the speakers. We have with us Dr. Quresh Maskati, sir, and I was trying to Google, sir, to get his resume, and I just realized that his ophthalmology experience is more than my age. So it's an honor to introduce him. Sir is super specialized in diseases of the cornea and anterior segment microsurgery. He has over 2 dozens of scientific publication in his name in national and international journals. He is co-author of chapters on ophthalmology in 12 books. He was the past president of Maharashtra Ophthalmological Society and Bombay Ophthalmologist Association and AIOS as well. He is recipient of various awards like VK Chitnis Oration by Moss, APAO Achievement Award, the prestigious Centenary Gold Medal by the Egyptian Ophthalmic Society for his work on keratoprosthesis, and the Lifetime Achievement Award by the International Society of Cornea and Keratorefractive Surgeons, to name a few. I really had to choose which one to tell. So thank you so much, sir, for joining us. Then we have with us Dr. Pankaj Varshney. He is director at Pushpa Govind Eye Center in Delhi. He has done his LLB from Faculty of Law, Delhi University. He has done his PG diploma in Health and Hospital Management from RML Hospital in New Delhi. He is ex-assistant secretary of Delhi Medical Association and senior vice president of Indian Medical Association. He is attached to Jaipur Golden Hospital and Max Hospital as head of department. So thank you so much, Dr. Pankaj, for joining us. So without wasting any more time, I would request Dr. Maskati, sir, to please share his screen. So So meanwhile, we are getting ready. Let me remind to our audience, you can put your questions in the chat box here and we will take them towards the end of the session. So if
Yeah.
you're talking, we are not able to hear you yet.
Yeah. Let's, we'll start from the beginning. I think okay. So my presentation, thank you, Aarti, for those kind words and for picking and choosing from my biodata. What is relevant is that I do surgeries, and when you do surgeries, you land with complications. And when you do enough surgeries and you have so much white hair in your beard, you tend to have more complications than most of the people in the audience. So I did have this dreaded complication when my patient died in the operation theater. It wasn't a cataract patient, but that doesn't matter because everything else is equally relevant. So this presentation is based on an actual incident. This is a patient with multiple medical problems. You name a problem, he had it. Patient was obese with thyroid disorder, diabetes, hypertension, heart disease, collagen disorder. They called me up from Indore saying that he had bilateral corneal perforations because of the collagen disorders. And the local eye surgeons there had told him the necessity for the corneas to be saved by emergency surgery. And of course, no one in Indore wanted to touch this gentleman. So on the phone itself, I'd explained to them the necessity of general anesthesia because I needed to do both eyes at the same sitting. And that I was planning amniotic membrane grafts. When their relatives came and met me, I spent almost an hour talking to the relatives and briefed them about the distinct possibility of death on the table because my anesthetist had seen the patient and given me this distinct possibility. So I shared it with them. They talked to the anesthetist also for about half an hour before the surgical procedure. So all possible explanations were given. Time and again, we had talked about the possibility of death on the table. And they had agreed to everything. Of course, they had given all the consent, special consent for the GA, and everything else had been taken well in advance. The inevitable happened. The patient had successful surgery, came out of anesthesia, was wheeled out of the operation theater on a trolley. So he was on a trolley and he was awake, he was conscious, and he said hello to the relatives. Then while he was still on the trolley and to be transferred to the room, bed on the room, he had a sudden cardiac arrest. All attempts to resuscitate him, we of course wheeled him back into the operation theater. We have cardiac monitors, we have the defibrillators, all that is present in my OT. All attempts to resuscitate him failed. We called an ambulance to shift him to the ICU. There's an ICU in a large hospital just across the road. But the cardiologist with the ambulance came in about 5 to 7 minutes. He was in my OT, but the cardiologist declared him dead. In my OT itself, he declared him dead. So what next? The relatives at that time were very understanding. They said, sir, just give us the body. We'll take him back to Indore by train. No one will know anything. So I said, no, that's not possible. See, why we say no, that's not possible is because today there are 6 relatives with the patient. Tomorrow you will find relatives in New Zealand, Papua New Guinea, and in Timbuktu who will say, why did you do this or why did you do that? Why did you pack him off to Indore? Suspicious. You have done some lafda, you have done some problems. So the correct thing to do is to refuse, even though it's in everybody's interest to quietly take the body. I refused. I told them that as per law, I have to call in the police. So I called in the police. Of course, first, before calling in the police, since the relatives were understanding and they were with the patient, myself and the anesthetist went back into the OT and made sure that all our OT notes were up to date. The minute by minute record of the anesthetist was made, saying at so and so time he did this, so and so time he did that, and so on. I need not have rushed because the police took their own sweet time in coming. Their police station is 10 minutes away from my hospital. They took 1.5 hours to come, then asked me why we had bothered to call them in the first place. So police are working at a snail's pace, obviously for ulterior motives, because they want someone to bribe them and get this matter over with. The police requested me to get a friendly family physician to certify that the cause of death was a heart attack. And then, as the relatives also want, the police asked me, why are you resisting giving the body? Just give the body to them, call a family physician, get a cause of death as heart attack, and give the relatives, and we won't say anything. I refused again. So first, I refused the relatives. Second, I refused the police. I said, I will not call a family physician. I did not want legal trouble later. So then the cop said, we will have to do a panchnama. I said, please proceed. So the cops requested for 5 witnesses. I got 5 witnesses from my hospital who are called panchas to be present. And then the cops then started talking to the relatives, taking their own sweet time. When did you leave Indore? All sorts of irrelevant questions were asked to the relatives. The cops then explained the further procedure. They said, after the panchnama is over, they would send the body to the state government hospital. In Mumbai, we have state government hospitals and we have municipal hospitals. A death like this is sent to the state government hospital, where a post-mortem would be conducted, authorized by the coroner. So in Mumbai, we have the coroner system. Not every place has a coroner system. Different places have a different, but most of the large metros have what is called a coroner who authorizes a post-mortem. So the police explained to the relatives that first we will do the panchnama, then we will send the body to JJ hospital, where a post-mortem will be conducted, authorized by the coroner. Then the JJ hospital authorities will issue a death certificate. This would have to be taken to another government office, which would then issue a permission certificate for the body to be taken out of the state. So this is only because the body had to go back to Indore. So this is the procedure that the police explained to us as well as the relatives. The cops were really taking their time. Since I had a clear conscience and the relatives till that time were still with me, the cops were getting quite frustrated. They took over 2 hours. So they took 1.5 hours to come. Then they took 2 hours to record just 2 pages of statements. Finally, they called the government hearse to take the body to the JJ hospital morgue. By this time, the relatives were getting tired now. Sensing this, the peons in the morgue, the class 4 employees in the morgue told them, no, there are so many other bodies in the queue and things could get delayed by hours unless you give me some speed money to hasten things up. I had sent my hospital manager with the patient's relatives. In spite of that, the relatives struck a deal with those peons. They readily agreed. They gave the peon all the money they had. And the post-mortem, lo and behold, was finished in less than an hour. And a certificate was issued. They said there is no need to go to another office now. Hum log sab kuch kar liya hai. The morgue attendants themselves then accompanied the body and the relatives to the railway station. They completed the paperwork required with the station authorities. They got the train delayed by 10 minutes. They put the body in the luggage compartment and they got purchased tickets for the relatives for the second-class compartment for the 18-hour trip home. I didn't know all this was happening. So while the body had gone to the JJ hospital for the post-mortem, I had contacted an undertaker in Mumbai who had, I had told him, I will pay you to embalm the body so that you can embalm it. And then the next day I could send it by plane. That was what because I didn't think it would take, I thought it might take long. It might be nightfall. All this happened, started at about 12 noon. But by the time I was talking to the undertaker, it was about 6 in the evening. He says, yes, doctor, when the body comes from the postmortem, I will embalm it. We will put it in a coffin, and we have got arrangements with the airline. So we will ship it the next day by air to Indore. And I found out the price also, and everything was negotiated. But unknown to me, the relatives had done all this on their own. So what are the lessons to be learned? What are the lessons that I learned? And what are the lessons that all of us can learn? Number one, stay cool. Take the relatives into total confidence. If its patient is bad risk, spend enough chair time with the relatives. There is no such thing as less time. I told you I spent an hour. Before that, I spent time on the phone with them in Indore. Then I spent an hour telling them about all the risks. My anesthetist separately spent half an hour with them. So explain everything to them. Obviously, take all consents possible in writing. If you want, you can take a video consent of this also, but at least take everything possible. Don't do it on a standard consent form. I agree that anything can happen, including death. Not like that. I have been explained that there is a very, very real chance of death happening on table or immediately after. I've been explained the patient is bad risk. So all those things were written down by me in hand, and then they signed. When the death occurs, don't leave the hospital under any circumstances. And this is not learning from my example, but I'm giving you the story of another eye surgeon who had this happen to him about 15 years after this. My story is about 15 years old. So who had this happen to him just a couple of years ago. He made the cardinal error of leaving the hospital and going home and leaving the discussion with the relatives and with the police to be done by his juniors, by his RMOs, resident medical officer. So don't do that, because the cops can easily browbeat the junior doctors, and the relatives can browbeat the junior doctors. So don't leave the hospital under any circumstances till everything is over. And you're also, the relatives see that you're spending the same time as they are spending. So you don't consider it a waste of time. You're with the relatives, you're talking to them all the time, counseling them, trying to see what is the best way out for them. And you must have a basic understanding of the law, which is why we are having this symposium. You must call in the cops. Insist on the cops and insist on the post-mortem. These two things will save you in the long run. As I said, if a relative pops up from Jumri Talaya in India or Timbuktu in I don't know where Timbuktu is, sorry. Geography is not my strong point. But if a relative turns up from any other part of the world or anywhere and says, why did you not do this? Why did you not do that? And suspect some tomfoolery, you got everything in evidence. You got the police statement, the panchnama, the postmortem report, everything you've done according to the law. So this is the first lesson. Remain cool and remain in the premises. Don't move. Second lesson, read page 13 and 14 of the AIS CME series on legal aspects of ophthalmology. It is book number 27. It's compiled by our own Dr. A. Deshpande, who is with us here. So you can request him for spare copies of the book, or even the soft copy can be got from AIOS. But it's has a wealth of information to cover this issue. Understand from this that as a doctor, you cannot be arrested. Even if a patient dies on table or in your hospital, you cannot be arrested. It is not an automatic arrest. Though it is a cognizable offense under section 304A, according to the Supreme Court ruling, there is no automatic arrest. So don't worry, you're not going to be put in jail. A death at our hands, either with consent or without consent, if the surgeon or the treatment is done in good faith, earns us exemption under various sections like 88 and 92 of the IPC. So be very clear. Don't be afraid. The law is actually on our side. It protects the doctor. When you don't know the law, then the police can browbeat you. The relatives can browbeat you. You start paying money. You start sweating. You start paying money under the table to everybody. Not required. So lesson number 3, Don't try and bribe the cops. It's not required at all. And don't submit to blackmail by the relatives or pay them hush money to hush up the matter. You don't want to hush up the matter. Your conscience is clear. At most, you may not charge your surgical and nursing home charges, or if you've already charged them, you may refund them if charged as a goodwill gesture, making it clear that this is not an admission of guilt. So this is what I did. I charged them the fees. I refunded the fees to them. I said, we tried our best, but you will need money to go home or to take the body home. So you please keep this. So initially they said, no, sir, you keep the money. I said, no, you take it. So that is individual. If you don't want to refund, you need not refund, but it's a good practice, goodwill. You can always earn from live patients. So in conclusion, don't wash your hands of the situation. Stay in control. You will never need to spend a minute like this behind bars if you don't panic. Everything wrong occurs when you panic, lose your cool, or try to pay money. May you, of course, never face such a situation. And we've got experts on our panel to tell us how better we can handle this. Thank you so much for your attention.
Thank you so much, sir. Deshpande sir, do you want to comment anything or should?
Yes, I want to comment. This, as Quresh said, the book is also available on Google.
Okay.
So just you can download it, and one can have the book on for their references. And whatever Quresh has said is extremely correct. And if it is followed, nothing like that. Only the thing is that many times you have to only inform to the police that such and such thing has happened. Please do the postmortem. Have a received copy with you. And then it's a true reference that you have referred to the police, and that is the further thing that police has to do whatever they want to do. So the ball is in the court of the police. So routinely this is sufficient, but Dr. Quresh has taken extraordinary pains, and really he has done a good thing and a good model thing that we should follow.
Before we go to the next speaker, Maskati sir, I have one question for you.
Sure.
So supposingly you have 5 cases in the line, and this has happened with your first case itself.
Yes.
And mentally also you are a little occupied. You have to do so many XYZ things. So how do you handle the other 4 patients in your list?
Yeah. So Aarti, the good thing is that I get very few patients to operate on, so maybe 1 in 6 months or so. But jokes apart, suppose I have 5 patients and this happens to the first patient. First thing we do is we go out and tell all the other 4 patients that we are closing down the operation theater because the sterility is not maintained. Because we've had lots of people coming in and out. Now, if a patient dies in your OT, you have lots of people coming, rushing in, rushing out, so there is no sterility. So we tell them that the optimum sterility is not there in the operation theater. So therefore, any further surgery cannot take place till I refumigate my theater. So we will have to postpone the list for today. We will be in touch with you. We have your phone numbers. We'll reschedule you. Thank you. And if you would be so kind enough as to leave the premises. So have less people there. You don't want shor sharaba. So get rid of all your other patients immediately from there so that you can concentrate on just this.
Okay, sir. So,
Maskati sir, very good evening. Thank you for such a nice talk. I want to ask one question, sir.
Yes.
Many of we juniors work at very small level nursing homes.
Yes.
Which are very little equipped, and it has only eye as a particular stream. Otherwise, no other segments are practiced in that particular nursing home.
Of
I
course.
had one case where a patient died after going to home, as the patient went to home. But one of my friend had a case where the patient died on table.
Yes.
So in those cases, sir, how to decide when and how to release the body? Probably she was the only doctor present at that point of time in the nursing home. It was a nursing home owned by an optometrist. Now, how to decide there, sir?
See, 2 things. One is, don't take the onus as an eye surgeon. you must call in. So suppose the death occurs on table, you must call in anybody from the town, a physician must be called. I presume there is an anesthetist present. If an anesthetist is present, they will know all the physicians in the town. So call the nearest person there. Let that physician come in and certify also that this patient is dead, or that he tried to revive and it's not possible, or it was dead on table. So involve a physician always after a person dies in your OT. And the remaining procedure, as I said, you have to call the police, inform the police, as Dr. Deshpande said.
One thing here, when you are operating a patient, you should see the standard of that hospital also. If it is registered by an optician, little bit it is an illegal hospital, because hospital should be registered under the doctor's name only. Secondly, whenever there is a surgery is going on, there should be there is no law, but it is on the safe side of the doctor, the anesthetist should be present in the operation theater as an anesthetist. Though you are giving the anesthesia, he will be present as an anesthetist and a second medical person who will take care whenever there is an emergency. Because many times the anesthetist is not there and courts ask why the second person was not there. Whether you will going to stop the surgery and take the care of the patient? Yes, doctor said yes. Do you know how to take the life-saving things? And then the question comes, you are not trained that much good as the anesthetist or the physician for life-saving things and life-saving procedures. So one best have a second person, though which will share your all responsibilities, and you will be responsible for only your eye.
Thank you so much.
Another small thing for those in small towns, IMA and many organizations organize courses on CPR, basic CPR, cardiopulmonary resuscitation. It would be nice to attend one of those and get a certificate that you have got training in CPR. So that will, as Dr. Deshpande, suppose on the off chance that you don't have an anesthetist, at least you can show a certificate that you're trained in basic resuscitative techniques and therefore you applied those. So otherwise they will say you're merely an ophthalmologist.
Okay, sir. That's so nice. Thank you.
Thank you so much, sir. So because of some internet issue, Dr. Pankaj had to record his presentation, and I'll be playing that from my end. Let me know if there are any challenges.
I am Dr. Pankaj Varshney. I will be speaking on medico-legal issues related to cataract surgery. Although there are so many medical complications of cataract surgery, I will try to explain with one example. Medical negligence is an act of commission or omission. It is defined by Boland's test, which says that failure to act in accordance with the standards of average prudent man at that time and place. It involves reasonable degree of skill and care. That means doing something which a doctor of average prudence does not do, or not doing something which a doctor of average prudence does. Burden of proof is always on the complainant who has to prove his case. But if doctor puts some defense, then he has to prove it. For example, valid consent and one of the accepted methods or common complications as per literature. Important complications which can invite consumer case against ophthalmologists include posterior capsular rupture, vitreous loss or nucleus drop, corneal decompensation, cystoid macular edema, endophthalmitis, vitreous or suprachoroidal hemorrhage, retinal tears or disc detachment, lens dislocation, aphakia or secondary IO. Pattern of cataract negligence cases in consumer courts shows that 91% of the cases reached national forum. Negligence was proved in 36.36% of cases and compensation was awarded. Pre-operative comorbidities, both systemic and ocular, were present in 50% of cases. Most common post-operative pathology leading to allegation is endophthalmitis. Highest compensation awarded is 9 crore 85 lakhs by Madras High Court. I will discuss two real cases. I will not disclose the identity of the surgeons or patient or year, but One is in favor, one is against, both on endophthalmitis. From these, we will understand few important points and we will learn. In case 1, which was in favor, complaint was negligence in operation and implantation of poor quality of lens, which led to infection resulting in removal of his right eye. Tests required prior to cataract surgery were done 1 month back. It was a case of res ipsa loquitur, as the surgeon admitted that the complainant was suffering from endophthalmitis, and referral letters did not mention the type of endophthalmitis. In this case, National Commission observed that eye surgeon was qualified and experienced. The complainant has not filed any evidence to prove that surgery or lens were of poor quality. That means it is a complainant who has to prove that surgery or lens was of poor quality. Also, 6 other patients who had underwent the surgery on the same date were without any infection, and there was no evidence of cluster of infection. Therefore, infection was not due to low quality of lens or poor surgery. The post-operative prescription clearly mentions that complainant had vision of 624. This shows importance of records. The pre-op lab test and medical checkup which were conducted 1 month prior to surgery was normal. Hence, there was no necessity to repeat the test again unless the patient had any signs or symptoms. This is not negligence. Opposite party referred the complainant to medical college at Jabalpur for management of infection, but it could not be controlled and ultimately the eye was removed. Referring a patient to higher center is not negligent. Several medical texts, literature and journals have revealed that endophthalmitis is a known complication of cataract surgery. This was also explained to the court by these examples. Intraocular infection is not only rampant at eye camps but also in hospitals, which include 5-star ones. Only surgeon who does not have endophthalmitis is the one who does not operate. It shows that every surgeon has to undergo some type of complication in his life. The problem is general, and despite the best possible care, mishaps cannot always be avoided. It is not surgeon who is to be always blamed, although he is responsible for the surgery. In view of aforesaid findings and discussions, we are of considered view that opposite parties acted as per standards of practice and there was no negligence or deficiency in service. Therefore, revision petition is dismissed, no order as to cost. Second case, which was against the ophthalmologist in State Consumer Forum, but in National Forum, it was in favor of the doctor. In this, complaint was the complainant visited eye hospital for eye checkup. The opposite party examined him and found cataract changes in both the eyes, left eye more than right eye. He was advised to undergo cataract surgery. He visited the hospital as advised for surgery and deposited rupees 28,000 as asked for. Cataract surgery in left eye was performed without pre-operative investigations by opposite party. He was discharged after 1 hour of the operation with an advice to report next day. He spent sleepless night due to a lot of pain in his operated eye, contacted the opposite party and he was advised to take few painkillers. Next day, he had been in the hospital with severe pain, redness and swelling in his left eye. He could not see anything when the bandage of the eye was opened. Then he was referred to another eye hospital. The complainant was immediately admitted in the hospital on the day of his arrival. Next day, he underwent anterior chamber wash, pars plana vitrectomy, intravitreal antibiotics under local anesthesia. The complainant suffered immense pain and suffering and after this surgery. Next day, he was examined again by the doctor and underwent intraocular lens removal plus repeat vitrectomy plus intravitreal antibiotics in his left eye under local anesthesia. He was discharged by the hospital of Chennai and with the direction to come back after 1 week for review. The complainant requested for the copies of the original documents, but the same was denied by the hospital and only the case summary was given. He was asked to come back for further review after 2 months. The opposite party never discussed anything regarding the details of the lens, such as make, manufacturing date, expiry date, and other details. No formal discharge summary was also given to the by the opposite party. He was only given a referral letter. The complainant suffered vision loss due to the use of expired lens and or retained intraocular foreign bodies. Defense proof given by the ophthalmologist were they denied and disputed each allegation separately. Visual acuity of right eye was 612 and left eye was 624 with glass before surgery. Pre-operative investigations like blood sugar, blood pressure, lacrimal sac syringing, intraocular pressure, keratometry, and A-scan biometry was done. Phacosurgery with implantation of foldable IQ intraocular lens of +22 diopter under local anesthesia was done. Surgery was uneventful and the patient had no complaint after leaving the hospital. On the next day, he had no major complaint and visual acuity of the left eye was 618 part with no undue anterior chamber reaction. After 2 days, the patient came with a complaint of pain, redness, and diminution of vision, suggestive of post-operative endophthalmitis. The patient was immediately taken for intravitreal vancomycin injection and other aggressive medication was also suggested, and therefore there was advice to come for follow-up. Next day, seeing the condition of the eye, the patient was referred to other eye care center, and patient requested the doctor that he has to be referred to a hospital who knows the opposite party. There was no negligence in referring the patient to eye care hospital, and the opposite party had followed all protocols required for carrying out cataract surgery. The patient has lost his vision in the left eye due to retinal detachment, which occurred during course of surgical procedure for treating post-operative endophthalmitis as per the records of the eye care hospital. What court observed? Court observed that expert opinion, in this case, there was an expert, and this expert said that negligence was there. So court said that expert opinion was not objected to by the other side, which says that the protocol of cataract surgery has not been followed. Whoever comes for expert while during the consumer court, before starting the case, we have to give application that we will cross-examine the expert if it is against us. The surgery was conducted without knowing the type of cataract. It is a gross medical negligence. Blood sugar was not checked on the date of surgery, admitted by the opposite party in his written statement. The patient was not referred to mainland big hospital and was referred to a friend. So the opposite party was negligent. No document was produced to show that post-operative advice was given to the patient. There is lack of records in this case. There was various serious lacking in the pre-surgical medical workup and investigation. Patient was discharged after 1 hour of the operation. The discharge summary was not given. The record or treatment charts have been clearly manipulated. So records have not to be manipulated at all. There was deficiency of service on the part of the opposite party. The opposite party was negligent and careless in handling the patient in pre-operative, operative, and post-operative stage. Court's decision. The complainant stands allowed for total damage of rupees 53,94,687 and 45 paise only, alleging medical negligence and deficiency in service. The opposite party is directed to pay the compensation amount within 6 weeks from the date, failing which the complainant is at liberty to have conclusion. Records, records, and records. We have to always keep all the records. Do not manipulate records. Prepare your defense by yourself. Complete medical pre-operative workup should be done. Records of giving advice to the patient in such cases should be kept. Refer to the nearest higher center, preferably government. Deny each allegation separately. Don't accept any mistake and object to expert if it is against you. Recommendations are professional indemnity insurance should be done, as with time more and more consumers are getting aware of their right. We must follow the standard procedures for medical care. Always choose the case which is within the capability of the surgeon. Good practice is not only to run for excellent vision, but referring the patient at right time and to the right place without taking cases on his ego. Availability and behavior towards the patient are two most important components in preventing such nuisance options. Thank you.
Over to you, Pankaj sir, for your comments. Sir, you are muted. Sir, please unmute yourself.
Oh, pardon?
Yes. Now I'm audible now, I think.
Yes, sir, you are audible now, sir.
My point of view is whenever we are doing cataract surgery, before doing surgery, we should spend 10 to 15 minutes with the patient and explain them the main possible complications during the surgery, including PC rent and nucleus drop, so that they are ready to hear it after the surgery if it happens. While I am doing my surgeries, I always spend 15 minutes with each patient's relative, and I ask them to write in their own handwriting that they have understood all these complications and they have no more questions. And after that, when I'm doing surgery, I'm at ease. Whatever occurs, I will tackle it. Consent is most important thing before taking the patient into the OT. Plus, whatever records we have to keep them. We have to write OT notes also in strict compilation, so that whenever case goes to consumer court, you have complete records with you, including OT notes, pre-operative workup, post-operative follow-up, and before making discharge to the patient, your file should have notes that post-operative general condition of the patient is good, pulse is good, and then patient is discharged. And if any problem occurs with any patients, one must keep all the records of that patient, because these records will only save you in court of law. Nothing else can save you. And records should not be manipulated. Records should have date and time and serial number of the pages also. And record of 1 day record should be in the same handwriting, same pen. If it is blue, it should be blue. It is black. There should not be any cutting or whatever happens. It happens. We have to take care of the things. We have to safeguard ourselves. We have to tell patient before surgery that all these possible complications are there. If he is willing, we will operate and come back. Most of the cases, they come back.
Thank you so much,
Any
sir.
questions for me?
Maratha sir, would you like to comment?
Yes, I will like to comment on this.
Yes, sir.
Yeah, the thing is that complication is not a negligence at all, because complications are going to happen, and those complications which are written in the textbooks and journals, they are taken as complication and not the negligence. But not knowing the complication in time, not taking the steps to rectify the complication, not referring the patient in time to the superior hospital where the facilities are more, that is the negligence. Secondly, when you are taking the patient for surgery, the medical fitness is must, though it is not legally binded, but it saves 100% you at any level. So fitness from a MD medicine person is very much saves you in the court. So the court has nothing to say that you have not taken the care of the patient's health. Thirdly, whenever there is a record keeping, record should be as such what the Dr. Pankaj has said, and that should be clearly mentioned and nicely mentioned. And if the records are maintained nicely, they come in the court, for your help. Again, one thing, the substandard lens, if put inside and that is recorded, or if there is a record, there was no previously clause in the old Consumer Protection Act, which was taken as negligence. But new Consumer Protection Act has a clause, that is a clause is showing that the below standard services, that is below standard production or services, is itself a thing which is Consumer Protection Act gives the compensation to the patient. So this act, this clause is new, and so even if you have not done any negligence, but your services are the below standard, you can be prosecuted for that. And it is very difficult which is below standard and which is standard. It is very difficult to settle in the court, and you have to prove a lot of things to say that my services were standard.
But any
Hello?
lens or any product which is allowed by code by government cannot be substandard, because that is allowed by the government.
Yeah, that's true. But if you say that if you want to put a multifocal lens and you put a unifocal lens, that makes the difference there.
The substandard means below quality lenses.
Below quality,
but below quality lenses are also authorized to be sold by the government.
That is true. But such things happens many times. Assured is something and given is something.
In our hospital, we have made it mandatory physician's clearance and PAC before.
That is a very good thing. That is a very good thing.
And sir,
Hello,
now
may I come in? Hello, may I come in?
Trend of giving away the lens boxes as well. So supposedly,
one should not give lens boxes. Only sticker should be given. As much material you give to the patient, you are more in trouble.
Hello, may I come in?
Nowhere it's written.
That should we give the lens boxes to the patients or no? Because it has been in practice in fact in Pune as well, in lot many big institutes.
Hello.
Yes, sir.
Yes,
Hello.
sir. Yes.
Am I audible?
Yes, sir.
Yes, sir.
Go ahead.
Good evening. First of all, I'm very sorry because parallelly I was present in one of the physical sessions as panelist. So, but I was hearing all those two talks. First important thing is about Dr. Quresh Maskati's lecture. It was fantastic lecture. The important thing is was like to escape from that very bad scenario, very bad experience, and goes through that particular the practice. One important thing is what we have said, that 304A11 must remember. Most of us know about 304A, and at that time you should take legal help of the medical legal experts like Dr. Deshpande sir. Because if you are telling about 304A, you are not arrested, and then it is non-valuable also. And that particular scenario, what Dr. Maskati sir explained, it is not easy for youngsters. They may lose their practice, but they should not lose the hope, and they must fight the case till the end and shouldn't lose their heart. Another thing is about Dr. Pankaj sir's various cases, what he has explained in a nice way. I think recent incidents of attacks, what most of us have experienced across the country. We were talking about the IL, that particular quality and standard, but all those things were different from various labs when they were checked, and the scenario was blamed for the doctors only most of the times by the patients, but not all the time it is the doctor's fault. It is maybe the laboratory fault or maybe some consumable fault, and we should be able to track that properly, locate that properly. And if the medical legal case occurs, this is my question to Dr. Deshpande sir and Dr. Pankaj sir. In that case, what is to be done? Suppose the patient has got some complication, and that is not because of surgeon's fault, but the fault of consumable or IL. What is to be done?
The thing is that if the injury is because of defective structure of the lens or defective manufacture of the lens, then the doctor can put a consumer case on the company.
No, but this was generalized. It was not individual. And in this case, most of the time, the company says that they were not at fault. In that scenario,
No, if
how
you
the
have a
blame
good
is to
record,
be
if it is a
not to be
broker,
accepted by surgeon.
then it is only possible. Otherwise, wherever if the infection is there and it is proved that your rigor lactate was infected and shown by the pathology lab, or your visco was infected and it was caused by this endophthalmitis, or your lens was infected, then these are the things which you have to prove with the supportive evidences and put a case to the company. Otherwise, company is not taken into consideration by the court. You have
One
to
more
put
thing.
One important thing about the yes, sir. Yes, sir. Please continue.
so moto code doesn't go to the company.
Pankaj, sir. Yeah.
So one more thing, whenever you get a notice, first of all, you get a notice from advocate of the complainant. Whenever you get a notice from advocate of the complainant, please do not reply it. Advocate's notice has not to be replied, because when you reply with your explanations are taken by that advocate as proof to fight against you in consumer court. You have to reply only notice by the consumer court, not by the advocate, because advocate is not law, consumer court is law. So what I have just recently within last 2 months, 3 cases in Delhi against ophthalmologists. All the 3 came to me, and 2 were only because they could not implant IOL. They left the patient a fake kick, and case was filed. It was advocate's notice first. I asked them not to reply. Let them, only one reply has to be given, that complainant has to prove his case, and let the complaint and explanation will to be asked by the local medical council or consumer court. Only then we will reply. Otherwise, I am not going to reply you anything.
Thank
I
you,
think
sir.
in
Thank
that
you.
case,
That
yeah,
would be
I think in that case, it is Applica is not the
I will
In first
like
case,
add
negligence. That can happen, and it is given in books. Yeah.
I will like to add something. As said by the Dr. Pankaj, it is true. It is not required to answer the advocate notice or the patient notice. But if you answer it without giving much details, only I deny this, I deny that, I deny this, and deny that, without opening your trump cards in front of the advocate, he cannot take the advantage of that reply to the court. And it is not necessary that you should not do it, but it is not mandatory to answer also. It is also true.
Thank you, sir. Thank you so much.
And about one more thing about the IL box we were talking about. I think it is the sticker what you can put to the case paper or patient's discharge card with your records. But the box of the IL is not to be given. If somebody is practicing that, I think it is not correct. It is not
should not
correct.
be given. Should not be given. As much material you give to the patient, you are more in trouble.
And the more issue about that box is about the MRP. MRP is very complicated issue with all those purchases by hospital, by doctor, then by medical shop. Some patient says that I will bring my own lens. Why don't you implant that? And GST and all that. So many complications are there. So not to do that box.
And please don't do any video streaming of your surgery, live surgery in your
in the past,
also,
few of the ophthalmic surgeons in the country used to give video cassettes of their surgeries. But that particular patient and relatives used to take that video to some different doctor and try to find out the loopholes in that surgery. I think that practice is stopped nowadays, and nobody should do that video recording. Even people had promoted relatives to see the video recording of their surgery, or they used to ask the people to sit in the reception area and the recording was shown. I think that also should be prohibited, because patients and relatives, they take the chance and try to find the loophole, and that goes against even medical legal implications.
Okay, I would have a question for Pankaj sir. How to about endophthalmitis? There is immense pressure when a young ophthalmologist or any ophthalmologist per se confronts a case of endophthalmitis. Now, who is going to pay for the referrals and for the treatment if in other hospital? So how to deal with that issue? Because that becomes a big issue whenever a case of endophthalmitis is diagnosed for any ophthalmologist. Because there's immense pressure, especially some political pressure or the surroundings pressure that the treating doctor, the treating hospital has to pay for whatever the referral is done. So how to deal with that? And does that come under the medical legal purview?
No, that does not come in medical legal purview. But what I am doing from last 40 years of my practice is, for every patient I operate, I keep ₹100 in one of the account. That is my corpus account. So if anything goes wrong, that corpus account can be used. Second thing, preferably the patient should be referred to a government hospital where there is no much expenses to be taken by the patient. And one must go together with the patient to the government hospital, higher center, and meet the HOD there and retina surgeon there, that this thing has happened and these are the problems and please take care. If you go personally to them, they will take care.
Okay, sir. And another thing is, Anand sir, do you want to add something?
I would like to add is that it is not necessary to pay the surgical charges of the retinal surgeon. But if you waive that and you pay from your pocket, patient is always pleased and the further actions are not taken. But if it is possible, then do it. Otherwise, let the patient to pay from their own pocket, because it is not mandatory on the primary surgeon to pay the referred charges of the second trial. Another thing is that in many medical colleges also, government hospitals are different, but even medical colleges also, all faculties are not there, particularly the retinal doctors are rarely seen, or in very few medical colleges it is seen. So you can refer to government hospitals also if the surgeon is available and quality of work is also good. Otherwise, you can send to your regular vitreoretinal surgeon whom you are referring the cases for other things. So he will help definitely to you, and the record is maintained by him, and that record is useful in the court also.
I think what Dr. Maskati sir had said in this case about the good justice to be shown. Suppose the patient is going for the higher referral like vitreoretinal surgeon, and if you are accompanying the patient, taking care of the charges sometimes, patient, even if there is a complication, patients and relatives, they feel good about the doctor, and they may not go to medical legal litigation against you. If they try to see that your behavior, your attitude towards patients and towards complication is good, I think their approach towards and your treatment changes, and that's what they can understand. That's what I feel.
Okay. Thank you, sir. Thank you so much. Maskati sir, this is for you. How does this timing of death, I mean, whether the death is before surgery, during any anesthetic procedure, during surgery or after surgery, how does that timing correlate with my responsibility if I am the operating surgeon? I mean, what is the legal accountability? Is that all same or it's different?
Absolutely no difference. It's just that luckily for me, the patient said hello, spoke to the relatives. So they were more understanding with me, that they knew that nothing had gone wrong in the theater and everything had, the patient came out well. But it could have happened on table, it could, instead of happening 15 minutes later. So medico-legally, there is zero difference whether it happens in the operation theater or outside or in the room.
Okay,
may
so
I
my
may I add something? Hello, may I add something?
Yes,
I think, suppose the death is occurring on table. What court and medical legal point of view the court sees that whether you have taken proper precautions to save the patient or not.
Yes.
Suppose the death has occurred and you have not tried anything. Any life-saving measure is not done by you or your anesthetists or your colleagues in the operation theater. Then it is treated as little bit negligent behavior from your side. But if you have taken all those precautions to save the patient, I think, and if that is properly documented, probably it is in your favor. That's what I want to add.
And that's why the second person should be there in the operation theater, either the anesthetist or the physician.
Okay. And Maskati sir, when the patient leaves the nursing home, as most of the cataract surgeries are daycare surgeries, those they leave the nursing home, they went to home, and after they died for probably some other reason. Now, can we be implicated that that was the day of surgery and we got implicated medically for that?
Good question. See, it depends on your records. Again, as Dr. Pankaj also pointed out, and Dr. Deshpande also, when a patient leaves my hospital, he signs a discharge summary. There are two discharge summaries I give. One is a discharge summary with the need for insurance purposes, and one is I am fine, I am fit, I have been discharged, and so whatever it is, and he signs there, and the time and the date is recorded, and a copy of that stays with me in my hospital. So I have full evidence that he was fine. The patient himself signs this, not the relatives.
Okay.
So the patient himself was fit enough at that time to sign this, and time has been entered, and I have a witness who signs over there, and that paper is preserved in my hospital. So then if he goes home and dies, he was fine in my hospital. After that, you are not responsible.
Okay, sir. So we have to have a written document which mentions that the patient is fine, and that is to be confirmed by either the patient or the relatives.
Not the relative.
Not the relative.
Again, I say, you see, most of our patients are under topical or local anesthesia. They are fully fit to sign. So unless it's a minor or something like that, a child of squint, then the relative will sign. But otherwise, I prefer the patient themselves signing, and I have my office staff sign as witness. And a time is put at which the signature was done. So the patient was discharged at so-and-so time. The signature is there of the time of 5 minutes prior to that he has signed this, and that he is saying that I am fit and I'm ready to go home.
And I will add to that, every laptop is having a CCTV camera at present in our hospitals. So it should be done under the surveillance of the camera. So it makes a good record, which cannot be refused by anybody.
For this, I would like to add, sir, that video evidence and audio evidences are taken as evidence only if they are deposited in a code before 5 p.m. of that day. If you keep them with you, they are not taken as evidence.
Okay.
As according to Evidence Act.
Okay.
All audio and video evidences have to be kept in a CD format and deposited in a particular any code before 5 p.m. Only then it will be taken as an evidence in your case. Otherwise, it will not be taken as an evidence.
Okay.
Okay.
So video recording has no value as per court of law.
Thank you so much. I think we had a great discussion, and the clock is showing 10 p.m. Any of the speaker or panelists would like to comment anything?
Yes, I would like to comment one thing.
Yes.
While taking consent, we ask patient to sign, one relative to sign, and we also have to sign on the same with the same pen and same time, and one witness. Witness usually hospitals take as relative of the patient, and this is the most dangerous thing, because when thing goes to court, you say something and patient says something, then witness will be called to testify, and if witness is from patient side, he will say what the patient wants.
So I will add to this. As per our AIOS has formed the consent forms, and they have taken all the care how to take the consent, and the form is very much complete, and every problem is tackled with that consent form. Secondly, only signature is not sufficient, because I have made it completely proof for the sake of court. Many times the patient says that this is not my signature. So thumb impression should be taken along with the signature that I have already mentioned in the booklet of the AIOS. And if it is done and followed, doctor will never come in trouble.
Yes.
Do we have any more? Maskati sir, would you like to comment something?
No. I think we've had a very, very good and healthy discussion, and I think there's a lot of take-home messages for the audience. So go ahead and say those magic words. Good night.
Thank you so much. So I would like to thank each one of you for making this session very, very interactive. And it was a great learning for all of us. And thank you so much, Deshpande sir and Marathe sir, for being with us and for guiding us.
Thank you.
Maskati sir, it was an honor to have you as a speaker. And Dr. Pankaj sir, your inputs were really, really helpful. Thank you, audience, for being with us. And thank you once again. Soon we will announce our next session. Once again, thank you and good night.
Good night.
Good night. Thank you so much. Thank you so much. Good night.
Thank you. Thank you, sir.
Good night.